CataractCoach.com, podcast series, episode number 112 with Dr. Sourabh Patwardhan, who says that gratitude and attitude will give your career altitude. Check it out. Welcome back to our Cataract Coach podcast. And today I have a very special guest. You've surely seen his videos online for teaching cataract surgery, especially phaco, and that is Sourabh Patwardhan. Welcome to our podcast, my friend.
Thank you, Dr. Uday. I'm so excited to speak with you, and I think you are one of the greatest teachers in ophthalmology. I've been following your YouTube video and particularly the podcast. So
Thank you.
so it's like going to a kind of a ceremony where everyone is getting some awards, and suddenly your name is announced. So that's how I felt when I got an email from you that you have invited me for the podcast. So it will be fun. It will be great fun.
Oh, for sure. There's so much for me and our listeners to learn from you. So I've really enjoyed a lot of your videos about basically phaco tips.
Yeah.
So your preference is, I'm sure you teach all aspects of ophthalmology and ophthalmic surgery, but you particularly love phaco.
Yeah. It's quite strange. I have specialized in retina to begin with. Okay. And when I started my practice 15 years back, when I joined my father, so both my parents are ophthalmologists, and my father is one of the first ones to start the phaco surgery in our area and IOLs long back, maybe in 1983 or something.
Wow.
So, but when I joined as a retina specialist, and I wanted to focus on only retina. That was my plan for first couple of years. But then I realized that there is a lot of fun in anterior segment. So finally, I became more of a cataract specialist as well.
Well, that's fantastic, because now you have the skill sets to do very complex, like anterior segment reconstruction cases. So for you, if you're teaching a young resident and the nucleus drops in the vitreous, no problem. You just do pars plana vitrectomy, lensectomy.
Yeah. So it was fun. Like when I was doing retina specialization with my consultants, who are all retina specialists, obviously. So, and they used to do cataract surgeries as well, but then they used to be, very relaxed once the nucleus goes in the vitreous, not purposefully, but if at all it goes, then they say, oh, it's in my field now. I can do a great job. So that was the thing. Yeah. But
right. I think it's particularly useful in a lot of these scleral fixated IOLs.
Yes. Perfect. Because we know kind of, the eye from the cornea to retina, everything. I think the imagination of the eye is most important thing in learning any skill. That's what I feel. Same is true with cataract surgery as well. Because if you want to do that horizontal chops, you want to know where your chopper is going, at what depth you are going, you should have that three-dimensional imagination of the eye, where the structures are. And I think doing a bit of retina definitely helps to get that perspective.
Oh, it does for sure. Plus, I think with these complex cases of like a scleral fixated IOL, we have to remember that Professor Yamane, or sometimes we say Yamani, but it's Yamane, he's a vitreoretinal surgeon. So those patients that he did the fixation on had full vitrectomies done. Because I see some patients in my clinic who have had scleral fixation done by an anterior segment surgeon, and it looks pretty good. But when you look carefully, there's vitreous traction with the vitreous in the haptics, and the patient has chronic macular edema because of that.
Yeah, that's quite true. So I think for scleral fixation, if you don't do complete vitrectomy, we are leaving some blind spots behind where we have not seen anything. So probably it's better idea to do a complete vitrectomy and then do a scleral fixation IOL. But of course, nowadays, many anterior segment surgeons are doing, or they have to do, these scleral fixated IOLs. So probably doing a good anterior vitrectomy and knowing the understanding of, the vitreous anatomy when they do that, it's quite useful.
Oh, for sure. I think one of the important skill sets to learn for an anterior segment surgeon like me, I've done no retina fellowship, but to learn from your colleagues, maybe from your retina professors, how to at least do a pars plana anterior vitrectomy.
Yeah, that's very, because there are situations where pars plana antivitrectomy is definitely superior than the limbal antivitrectomy. For example, you get a subluxated cataract where the vitreous is coming from behind. if you go from the pars plana and just remove that vitreous, it's not going to prolapse
Right.
back again. Also, in some cases where there is a peripheral posterior capsular rupture, so you can just preserve the entire posterior capsule if you go from pars plana. Otherwise, you try to go from the anterior route and it kind of extends the entire posterior capsular rupture. So there are few situations where you definitely should know how to do pars plana anterior vitrectomy.
Right. We have a sister channel now, retinarounds.com, which we started.
Amazing. Yes.
On March, yeah. Yeah. My host there, my good dear colleague, Pradeep Prasad's amazing. But
Yeah.
I think one of the most popular videos that he put was such a simple one, how to place the trocars. That's it.
Yeah. Yeah. Basics.
But yeah,
I
like
think,
you focus on that too when you teach.
yeah. So I feel that basics are way too more important when you are doing, in fact, the complex cases. Because unless your basics are really, really good, that means you know what to do and what not to do at all, you will
Right.
not be able to tackle those complex cases easily. So that's what I tell many, like we train many people. They are, a few of them are really beginner, like they have not touched the eye at all till they come to us, or some are already practicing, but they want to upgrade their skills.
Right.
So many times I get this request that I'm doing regularly cataracts, but I cannot do difficult cases. So can you teach me? And
True.
first thing I tell them that first I'm going to observe you doing your regular cases.
Okay.
So that's where many times the mistakes lie. So in a regular case, maybe these mistakes do not translate into complications. But if you get a complex case, you have the margin of error is suddenly now very narrow.
Right.
You do a small mistake, and the case is going kind of a bad way. So
Yeah.
the difference between tackling a complex case and a regular case is the margin of error. So in the regular cases, you have to be really, really good in order to be, you can easily then do complex cases.
Yeah, I think you're right. The basics, that's the foundation. And I like the way you phrased it. With a routine case, let's say you have a problem where you don't float in the incision and your incisions leak too much, but for a routine case, you may be okay. But now you have the case with the loose nodular support and a subluxated lens. Now you do that. Now you have a shallow anterior chamber. Now you have vitreous prolapse. Now you have a whole lot of trouble because the margin of safety is less.
Yeah. So, for example, if you are doing stop and chop or a primary chop in a regular case, and when you are doing that, you are putting a lot of pressure on the bag and the zonules, you might get away in a regular case because the bag is strong, the zonules are strong in that case. But if you don't realize that that is not what is correct, then you will not be able to do those difficult cases. So in regular cases, you should be flawless before you jump onto any complex case.
That's a great point. Just got to do it graded. In fact, we used to do the same thing when I taught residents. You choose the nice, very easy cases for the beginning residents, then you slowly ramp it up. Now, tell me about your training program. What do you offer for training? Do you train from first-year resident to senior resident? Do you do fellowships? What's your offer?
Yeah, so our institute, we have everything, right from the postgraduate students, which are called DNB students here. And we also have fellows who want to specialize in particular things, like we have in cataract fellowship, we have comprehensive fellowship where they do cataract plus medical retina, little bit of cornea, so they can be a good general ophthalmologist. And we have surgical retina as well. And apart from that, of course, our program is quite famous for the short-term training programs, which are more of customized. Like we get many beginners, at the same time, we get many practicing ophthalmologists also who want to just upgrade their skills. So they can come for a week or two, and they're already doing some, cases, but they find some difficulties in doing particular cases. So they can just come over, we supervise them, we give them good tips, and they can do better. So it's very, very customized as per the needs of those who come to us.
And tell me more about the short programs. How long are these? What's the range? Is it a few weeks, a few months? And is it open to outsiders, like someone from other countries like me?
Yes. It's open for you, definitely. So in short programs, basically it depends on how many days the trainee can spend with us. So many are doing probably jobs, so they do not get a long vacation. So They come for a week, 2 weeks. Uh, our common program is 3 weeks program, but
Okay.
it's always customized as per the need. Some trainees want to do more number of cases before they are in between the two programs, like they have finished maybe residency and they want to join a job or something. So they come for a month or 2 months to do more cases and learn better. So it's all very, very customized as per the need of the surgeons.
Oh, that's fantastic. Yeah, I mean, I travel a lot. I
Yeah,
like last year I give lectures in 21 countries, so there's a lot of travel. But in a lot of these countries, especially in some European countries, the
yes,
residents are not getting very much surgery, very low surgical
yeah,
volume. So a lot of them, I was talking to an Italian resident when I was in Italy a month ago, and those residents saying, "Yeah, we're doing a program. We're going to go to India and learn, and then
yeah,
come back
yeah,
to Italy." So do you have a lot of these kind of doctors as
lot.
well?
Yeah, yeah. We had trainees probably from all parts of the world, right from Korea to USA, from Sweden, Norway to Australia, South Africa, everywhere. And this is common problem, not just elsewhere, also in India. Also in India, not all programs have a good surgical training. So
Mm,
few of them have good hands-on surgical training, but many of them do not have. So they need to upgrade their skills before they jump onto maybe specialty fellowships or they want to go into practice. So I think the story is similar all over the world. So we need robust training program. There are few, but probably entry into those programs is not possible for all.
right. I think same in the U.S. In the U.S., it's a
Yeah,
believe it or not, for the U.S., we call this ACGME, the American College of Graduate Medical Education. Their requirement is in your 4 years of ophthalmology residency in the USA, their requirement is 86 phaco's,
that's
which
it.
is,
Okay.
which is like a busy surgeon in practice. You could do that in a week.
Yeah, yeah, I know. Yeah.
And so a
So,
lot, I think a lot of them, they may be in a program
mm,
where they don't get enough volume. So you may have even, yeah, plenty of American or USA residents wanting to come for a
yeah, yeah,
week or two and do, let's say, 100 cases.
yeah. They're coming, and but what I found, like different countries have different programs. So I find that U.S. residents, though they may not have probably exposure to more number of cases, they have seen everything, and probably one of the thing is I think they have got good access to simulators and wet labs.
Right.
So they do a lot of those, and those who have done those simulator programs, they are better off. So I think the message to them is that if even if you are not getting cases, if you have access to a wet lab or simulators, I think you should try to put your more hours into that. That will definitely help you when you actually get opportunity to do cases.
Yeah, exactly. I would tell residents that no one is born knowing how to operate under a microscope. No
Yeah,
one's born knowing how to tie a 10-0 nylon. So my
yeah,
requirement was too, I said, or my suggestions, we can't have requirements anymore. My suggestion was that you do the complete IC surgical training, the simulator, do the complete program.
yeah,
But then also in the wet lab, I want you to be able to do what I called the Devgan 10-10-10. I want to see 10 sutures of 10-0 nylon in 10 minutes. And do it
yes,
on get a tomato, get a grape, whatever it is, under the microscope, cut it, suture it, show me a video, 10 minutes. And I think
perfect.
if you can use your hands to tie 10-0 nylon 10 times in 10 minutes, that's pretty good.
Yes, perfect. So there are one of my good friend John Davis. So on my YouTube channel also I have put one of his videos. He calls it the kitchen lab. During the COVID times, he used the things in the kitchen to train, the your hands, like you
Smart.
said, tomatoes and everything.
Yeah.
And he even used a mobile phone under which he kept something. So mobile phone was used like a microscope, and under that he could, coordinate his hands. So there are so many amazing ways to
Right.
train yourself, even in absence of patients. That's what I feel.
Yeah, the hard part is just putting in the effort.
Yeah, I know. So I think one of your videos I listened to. I think you talked about the attitude of the
Right.
trainee. That's something really matters. So I have seen so many trainees now. Almost we must have trained almost 700 trainees in last few
Wow.
years. So everyone is different, and I think by different we mean the attitude also. When I see a trainee coming in, in the early in the morning, even if he or she doesn't have a case, but stays in the OT till the OT finishes. Okay, just watching, observing each and everyone operating. I
Right.
think that's what I call a good attitude. You know, so
Yeah.
that's the focus somebody needs if he or she wants to learn something badly. That's the kind of attitude everyone should develop, rather than coming into OT and see, I don't have case, okay, I will go, I will chit chat with others about anything except cataract surgery. That's not the right attitude to have when you are learning something.
Of course, I would always say that the diploma you receive is not the goal. The
Yeah.
goal is for every day to squeeze as much knowledge and experience and hands-on as possible out of every single day to
Yes.
maximize that.
Yes. So I think I learned, like, I feel that when I did my residency, I was good in academics right from the beginning. So I know my parents are ophthalmologists, so everyone thought that I am going to be ophthalmologist. I worked hard for my MBBS, that is the graduation, and I topped my state. And now I have got many options. I can do cardiothoracics, I can do endocrino and everything. And then I was confused. I think too many options confuse you a lot. So
Sure.
when I gave my first entrance for the post graduation, I got a good rank. But at that good rank, I was getting ophthalmology in RP Center AIMS, which was the topmost, which is the topmost institute in India. And I decided, sometimes destiny tells you where to go. So I became ophthalmologist, but then I decided that whatever I do, I must work very, very hard to not just be the best, but best in the world, whatever I want to do. So that should be kind of a passion you should have once you go into any field. So I think once you see that in any trainee or any resident, he or she is going to do well in his or her life. The time might be different. Some may reach it early, some may reach it later, but that passion you should have to reach that goal.
Of course, because if you have the passion, then it's not work, it's enjoyment. You enjoy learning.
Enjoyment, yes.
So
And
that's the key.
once you have that passion, you will get good people who guide you. You will get good mentors. Okay, that reminds me, a long time back when I joined RP Center AIMS, and one of my professor, Dr. Tanuj Dada, I think you know him well. He was putting a book together on phaco emulsification, and I was a second year resident at that time, quite new to ophthalmology. And he told me that you should write a chapter in my book. So that is mentoring for you. You don't believe that you will be able to do that, but
Right.
somebody comes and tells you, you can do it, don't worry, I know that you have capability, you can do it. So I wrote a chapter in that book, and then he gave me two more chapters. Okay, he told me, this has been written by a very, very dynamic ophthalmologist from USA, and why don't you have a look, and if you can add something to it, you can do it. So I did those. And you know who was the author? It was Dr. Uday Devgan.
See?
So and it was pretty amazing. So I said, when I put those edited, and then he told me that he's Dr. Uday Devan, he's one of the great ophthalmologists. So at that time I was just young surgeon in the ophthalmology who didn't know, but now I know who Dr. Uday Devgan is, and it's
Oh,
so
wow.
amazing
What a,
how
what a,
we
what
all
a small world.
connect.
What a small world, right? What a very small
Yeah.
world.
Yeah.
Ophthalmology for sure is a very small world. So that must have been 15 years ago, 18 years ago, a while ago,
Yeah,
right?
it was in 2006 or so. So 19
Wow.
years old.
Wow. Time flies.
Yeah, amazing. But I think these are the people who really, push you to do better and better in life. So,
Right.
uh, and whenever you go into any big institution, I think, uh, first of all, I think you always try to have some expectation from each and everyone. Like, this
Right.
person will teach me, this person will teach me. But I think we learn from each and everyone,
Right.
irrespective of what he or she actively teaches you. You learn leadership skills from someone. You
Right.
learn
Yeah.
how to be very, very kind of uh, clear in their mind, how to care for the patients, how to be very, very precise and accurate in the OR or in the OPD, in the documentation and everything. So you learn from each and everyone some good points. So I think rather than expecting each and everyone to be great or to teach you, you learn from them whatever they can tell you. So I feel that's what all residents should know, because I get many residents who are kind of disheartened because they are not taught anything during their residency. But I always tell them, see, you have learned many things which may not be surgical, but you have learned many things from these consultants and your colleagues. So you should try to imbibe good points from each and every person that you meet.
That's so true. And then just a little bit of a encouragement from a professor can set you for life. When I was a first-year resident, I was doing a retina rotation with Professor Stephen Schwartz at UCLA.
Yeah.
Fantastic retina surgeon. And he says to me, he said, I was a first-year resident. I could barely spell ophthalmology. And he says, he pulled me aside. He says, what is this? He says, you're better than this. You need to do much better than this. And he says, I'm not your friend, he said. He says, your friends accept you as you are. I think you could be much better than you are. Go and be, he says, do better. And you know what? Since then, I have to be the best resident he's ever seen. That's my goal.
Amazing. That's what. And that's again, I was with Dr. Stephen Schwartz for a week's time when I visited UCLA. It was in 2009, just after the American Academy. So Dr. Pradeep Prasad was also at that time probably a senior fellow with him.
Yeah.
So again, a small world.
Yeah, but I just love the way he did that. His attitude, like, listen, you can be better than this. I want to encourage you. But he was a little bit of tough love for me, which is what I needed.
Yes. I think there are people, like, for example, in our RP center, there was Professor SP Garg. He will scold us in our rounds if I do any mistake. I give wrong answer, I don't have answer. But then we know that the intention behind that scolding is that I should become better. You should become better. So these are the teachers we need in life, definitely.
Yeah, for sure. Now, let's talk more about your program here. So when you're teaching a brand new doctor who's never touched the eye, done 0 ophthalmic surgeries, okay, how do you start? Where do you start?
Yeah. So first of all, if somebody mails me and tells me that, see, I have not done any cataract surgery, I have done little bit of maybe oculoplasty or other surgeries under the microscope. That means they have got hand-eye coordination going, but not done cataract surgery. Will I be able to learn cataract surgery? And my answer is 100% yes. Okay. Because I think learning cataract surgery is not difficult for almost 95% of ophthalmologists. So when we see the trainees who visit us or overall residents, out of 100, I think 5% are exceptionally good surgeons. That means they learn quickly. They have very short learning curve, and they can, whatever you tell, they will just follow what you tell, and they will then improvise. 5% are those who really struggle somehow with something. Okay. 90% of us are average surgeons who will learn with their own speed, but they will learn definitely. So whenever somebody tells me that, can I learn surgery? I say 95% you will be doing a very good surgery once you learn. And we always go stepwise. So I have a certain philosophy, or in my video on training hand and mind, you should always start with things which require less coordination.
Okay.
For example, in phaco, as you know, we need hand-eye coordination, coordination between two hands, and also the hand and foot coordination.
Right.
All three. Yeah, so many things happening together. But then a beginner cannot do that simultaneously. Okay.
Right.
So what I tell them is that first focus on two things together. For example, you want to do hand-eye coordination. Let's start with incision making. Okay. Let's start with little bit of cortex removal, where little bit foot comes into play, but not so much. Okay. Maybe IOL insertion, because then your foot is not into play. You just need to have a hand-eye coordination. And then we start doing reverse. Then slowly we go to trench, and chopping needs everything together. Your hand, your foot, your hand, eye, foot coordination, which is the toughest of all. So start with small things, or the single coordination movements first, and then go on to more complex coordination. So that's how we teach our residents as well as trainees.
So you're basically backing into the surgery. So
Yeah,
if you're a
kind of.
newbie, you could start with, okay, the surgery's done. You place a 1009 on the incision. That's what you start with today.
Perfect. I think suturing is something easiest to learn when you do it in wet lab hundreds
Right.
of times, like you said.
Yeah.
You do it, and you will learn. It's the easiest thing you can learn outside the theater.
Right. And then the next week, with the same resident, okay, now you can remove the viscoelastic at the end of the case.
Yes.
And then,
Yes.
then the next week, now you can insert the IOL.
Yes.
And the next week, you can do the cortex removal. So you kind
Yeah.
of back it in. That's very smart, because if you start at the beginning and they do like a bad rexus and run, now the whole case is a mess.
Gone. And another thing which I have realized, like, I think one of the commonest thing which hinders our learning curve or learning quickly is the hesitation that surgeons get when they start. For example, if I tell a surgeon, like a beginner, to do entire case, and then suppose I tell him that you start doing trenching and you divide it and do chop, and then what happens in his first go, he makes a complication. Now, the next time he operates, he is always hesitating. When you do trench, you know that you have to reach adequate depth. Otherwise, you will not be able to do division. But now, every time the surgeon thinks of that complication, the surgeon is hesitating to go deeper. And that hesitation is there in the surgeon's mind, no matter how many cases the surgeon does. So that's why I feel that when somebody says that I have not done any surgery so far, I say that it's very easy for me to teach you, because you don't have any bad experiences also.
No bad
You're
habit.
fresh. No bad habit. You're fresh.
Yeah.
But then if somebody has done 200, 300 cases and still not learned, that means he has already developed the bad habits.
Yeah.
And many times it's more of a hesitation. So in those cases, even if I tell them go deeper with the trenching, he will say no, I cannot do. I will make a
Right.
hole. I will do. And that's when you start going slow on your learning curve. So
The fear, the hesitation.
yeah. So I think the first 100 cases anyone does are most important cases of ophthalmic surgeon's life, because that kind of sets your mind. So if you are good, you are supervised, you are being trained with a methodical way, you do very less complication in your 100 cases, you are more confident of what you are doing, you are less hesitant, and you obviously become better surgeon, because now you can learn things much fast. That's what I have observed.
I think you're absolutely right. Those are such great points. So now, what's the order which you teach things? You must teach, like I would teach the residents first, but the first time you put a phaco probe in the eye, I will choose a 50-year-old patient with all 4+ posterior subcapsular cataract and like 0+ NS. Because then you can I'll get the nucleus out of the bag, you just put the probe in and just aspirate it. And then we go to divide and conquer. What was your process of teaching? Which order? You go like easy case, then divide and conquer, stop and chop, horizontal chop. What do you progress?
Yeah, so for first 10 cases, generally we ask the trainee to do capsulorhexis, hydrodissection, and depending on how the surgeon has done in the first steps, we ask them to start with the trenching. Okay, but after trench, we generally ask them to stop. We analyze. If the trench is not deep enough, we make it deeper, and then again ask the surgeon, now you try dividing. Because now what happens, the surgeon knows exactly how deep is deep.
Right.
So once I have done the depth and then ask the surgeon to divide, he knows next time he has to go that deep to divide. And then generally we don't give the chopping initially for first 10 cases. After 10 cases, we analyze like whether he has got a good hand coordination now. Is he pushing the nucleus still? Does he have a good control on the phaco when he's trenching, whether he's pushing too hard or too slow? If he's good, then we slowly shift to chopping. And we generally choose grade 2 and 3 nucleus sclerosis cases for chopping initially, because these are the easiest to chop.
Yeah.
And later we move on to the harder or softer grade of cataracts. So I think the first thing, and also for chopping, like sometimes what we do is that we chop one half, like heminucleus, and now we tell him that, see, now this is how we have done. You try doing it on the other side.
Sure, makes sense. Makes a lot of
So
sense.
because
Are you also teaching MSICS?
yeah, that's so in India, luckily, the first surgery that we generally do nowadays is MSICS and not ECC like earlier that was practiced. So MSICS is very useful technique to have. I think every cataract surgeon should know MSICS, antivetrectomy, how to
Right.
put a three-piece IOL, I think, and secondary IOL. So these four things any phaco surgeon should know. That will make a phaco surgeon an accomplished surgeon. I would say a whole package.
I think it's so important to learn those things. But in the US, I used to teach every resident how to do MSICS. I thought it was very important to learn this because obviously it's a far better surgery than the old manual ECC, which was terrible.
Yeah.
The corneal sclerosis, that was horrendous. So it's a
Yeah.
much better surgery. And there are cases where even in Beverly Hills, in this fanciest part of Los Angeles, I'm doing one, sometimes two of these in a month.
Oh,
It didn't seem
yes.
like much, but like I had a video recently of a patient with an absolutely brunescent cataract, and that's
Yeah.
the best answer for that case.
Yes, definitely.
That's a
Definitely.
lot of, in the US, there are very few surgical programs that teach it. So there are a lot of US surgeons, even specialty surgeons in practice, who don't know how to do it.
That's what I said. I think if a phaco surgeon doesn't know how to do a good MSICS, I think there are few cases where he or she may not be able to do a good job.
Right.
So, for example, you get those, corneal opacity cases where the visibility is poor. So, if you try to do phaco, sometimes you,
Right.
have bad complications. Also, in cases where the endothelial count is very poor,
Of
or the
course.
zonules are too weak, and as you said, the brown or brunescent cataracts. I think these are the, or sometimes I have done MSICS in post trabeculectomy brown cataracts where you don't
Yeah.
want to mess up with the endothelium anymore. So I
Right.
think these cases you really give vision back to the patient, and I think every phaco surgeon must know how to do a very good MSICS.
I totally agree with you. And that's why on Cataract Coach, I have very basic videos, like 4 easy steps to learn MSICS, and aimed at American surgeons who are already in the middle of their careers, who are great phaco surgeons, but they have to learn how to do this. Because as you said, there are cases where it is a better procedure than doing phaco in that one case, in that specific case.
Yeah.
The
Yeah,
other
and
thing too is, okay, please go ahead.
yeah, so I get nowadays many inquiries for learning MSICS, which is a good thing. Those who are already doing phaco regularly, I think knowing MSICS will give you a lot of confidence in tackling these kind of cases. It will make you another, surgeon, another level surgeon, definitely.
And that's easy to learn. If you get a surgeon who's done 10 years of phaco and they come to
Yeah,
you to learn M6, you can learn that in a week, easy.
easy. Yeah, easy. Yeah.
Even less, probably a few days is enough.
Yeah, it's very easy because they know the anatomy. So only
Right.
thing they have to learn is the scleral tunnel. Rest of the things they are already doing. So I think it's very easy for them to learn.
Right. They already know how to use their hands under a microscope. They've already done thousands of cases. It's good.
Yeah.
Those are easy.
So I think the difference between MSICS and phaco is that phaco is a technique and MSICS is like an art. So you should be able to learn how to use your hand in a better way. In phaco, your hand skills are, I would say, less required than when you are making a scleral tunnel in MSICS. So that is the only difference between phaco and MSICS.
Yeah, that's true. The other thing you said, which is very important, is you need to know how to do an antivetrectomy. 100% of surgeons, even the experts like you and me, at some
Yeah.
point, we're going to need to do an antivetrectomy. The capsule's going to break. There's going to be vitreous prolapse. You got to do it. And the poor, sometimes we get some poor residents who do their entire residency. They're on 100 phacos. And I said, have you broken a capsule yet? They said, no. And they're so happy. I said, no, you shouldn't be happy. You need to know how to manage this. Don't
Yeah.
graduate without knowing how to do an antivetrectomy.
Yes, that is true. That is absolutely true. As I said, my rule is that antivitrectomy also using three-piece IOL because many of them don't know how to put three-piece IOL in the sulcus. And when they have a complication, they cannot do it and they are not confident. So you kind of leave the patient aphakic after you do everything all well, and you cannot put a 3-piece IL properly. So I think that also one should learn.
Yeah, we've got great videos on Cataract Coach for this. I was recently at a meeting where they did a live surgery, and there was some complication. The surgeon put in a 3-piece lens, and it was upside down.
Yeah, I saw that.
And I was like, I teach this. Hello, you should know that. But sometimes you're under pressure, under stress, you don't realize it. So that's why it's like helpful to watch these videos and learn. Now, tell me about your video. You have a beautiful phaco channel on YouTube. We're going to put a link down below, so anyone who's listening to the podcast or watching this video, they can go onto your site as well. Tell me about your channel.
Yeah, so it's very interesting because, as I told, I was a retina specialist first when I joined my father and mother who were practicing here. And when I joined for first couple of years, I was confused whether I should just focus on retina or I should also learn cataract surgery. And at that time, my focus was not on cataract surgery. Though I was doing cataract surgery, it was not, as I said, it was not very methodical. So then I decided that I must start now learning phaco, a good phaco, not just, doing cataract surgery. So I told my father that I will start a fellowship program. Okay. Now my father thought that I'm crazy, you have already a lot of work doing here, and why do you want to teach a fellow? So I said, no, I want to learn phaco very well. So I want to start teaching.
Right.
So that's how I started a phaco fellowship program with this. And literally in my first 2 fellows, and I learned together, though of course I was better than them, thankfully. So I could teach them a lot of things. But then from that, and my father is, doing a kind of a live surgery since 1990. So since 1990, he had the camera to the microscope, and it was shown to the patient's relative outside, and we are still doing that. So when I operate, the patient's relatives can actually see the surgery happening. And so we had the recording system. So I recorded each and every surgery of mine, and we used to discuss the surgery. And when there was particularly a complication, it was exciting because then I could teach them what mistakes I did during that surgery. So that's how I started editing and putting those videos on the YouTube. And many of my colleagues told that these are very useful and you should keep on putting more, because we are learning in our practice also what you are putting. So many things we have to learn, like we have not learned in our residency, but you are showing them. So we can learn when we are doing private practice, which is great thing. So that's how the YouTube channel started, and I started putting up more and more videos. So during COVID times, I think it was really useful for many residents, because at that time the cases were very scanty, less cases, and they have to learn on their own. Where the YouTube channels, all these YouTube channels really help the residents.
Yeah, I think it's a really great resource. We have to be thankful to the godfather of surgical video, Bob Osher, who basically he taught the world how to learn from watching videos.
Yeah, it was really nice. I met him during ESCRS recently, and he conducts a very good program there on the surgical videos. And then he picks a few good videos and he shows them. And after that, he shows similar video which he has presented probably 20 years back, which is amazing. So it's like such a huge, knowledge that he has got, and he has spread across the world. Amazing.
Yeah, no, I think it's the videos, phone videos are amazing. I mean, I look at my statistics, and majority of the views we get are actually from mobile devices. People are not usually watching the videos on their laptop or desktop computer. It's mostly on their mobile device.
Yes. So it has been, and also with YouTube channel, I could meet so many great friends and learn so many things. Like 4 or 5 years back, on my YouTube channel, one surgeon from Brazil put some comments that these are really good videos. I could learn so many things. And I just searched like, who is this surgeon who is complimenting me? And he was Dr. Nito Rosatelli. He's an amazing surgeon, as you know. And I was this thing that he I think I learned the humility from him. Such a great surgeon, but always there to help. So I spoke with him a lot of times later and learned so many things. But I think that's the greatness of these great surgeons who share the knowledge and still have the humility to speak with others and still keep sharing. So I learned so many. My good friend Dr. Deepak Megur, he's an amazing surgeon, and he puts up a lot of videos on his YouTube channel. So many, and we also conduct a yearly program here called phaco Tips, which has live surgeries. And the amazing thing about this program is that we show everything in 3D. So all the didactic videos are in 3D. So the audience can actually see the depth of the trench, where we are chopping, how the
Oh,
zonules are weak, how the vitreous comes up, everything in 3D. So we have been conducting it for last 5-6 years now, and it has been amazing. So with that, we have also learned so many things. When we edit,
sure.
we show it to audience, we take their questions, we answer them. They also show some scenarios where we have to tackle. So it's amazing learning. So with YouTube, I think the world has become smaller. We are connected to so many great souls around.
Right. That's fantastic. Wow, that's great. Yeah, I like Deepak Magur's videos too. Beautiful videos.
Beautiful.
I sent him an email to invite him to the podcast. He didn't yet respond, so maybe text him and tell him, hey,
I'll speak with
you should.
him. Yeah.
Now, in your clinic there, in your eye hospital, of the cataract surgeries, what percent are phaco, what percent are MSICS?
Yeah, so we now do maximum phacos because our private cases are mostly phacos, except few cases, as you said, which really requires manual SICS. And for training, of course, because we get most of the requests for phacos, so all our training cases are also phacos. So I would say almost 96%, 95% are phacos, while 5% are SICS.
But you still offer MSICS. So if a young doctor
Yeah.
comes to train, they will learn both.
Yes, because we do almost like 2,000 surgeries. So even this 5% is quite good number.
Wow. So if someone comes to you for 1 year fellowship, how many cases they will do? About 2,000?
No. So for a long-term fellowship program, so we have a short-term training program, which are like small and there they don't work. The long-term fellowship program is more like a extended residency
Okay.
because they have not done so many. So in a year's program, probably they will get around 150 to 200 phacos over a period of time. But they will get to do all types of cases, even the complex cases, and they can manage other, anomalies also, not just cataract. So they become general ophthalmologists.
And then what about the intense short-term programs? Like if you have
Yeah.
an American surgeon who finished residency, he's only done about 100, 200 phacos, wants to be a better phaco surgeon, will come there for, let's say, your 3-week program. About how many could they learn? How many cases?
So the general, we see that a trainee can do around 15 to 25 cases every week.
Oh, that's great.
Yeah, so there are few surgeons who have done more than that. So those who are faster, they can learn quicker. But generally 15 to 20 per week is what we generally offer. And because we don't want to rush them also to learning. So that's also important. But few surgeons really want to do many cases. So we have surgeons who have done maybe even 14, 15 cases in a day. So, but we see to it that they learn rather than just doing the numbers.
Of course, that's the key. You have to
That's most
learn
important.
from
Yeah.
every single case.
Yes.
In
So
fact,
it's very important. It's very
yes,
important because sometimes they are just after numbers and they don't analyze the videos. I think analyzing each surgical video at the end of the day gives you much more information, and you are ready for the next day. That reminds me of a very interesting trainee we had. So he was 65-year-old
okay.
and he applied for the short-term training. And I asked him, what do you want to, and he was already doing phaco for last probably 25 years. So I asked him, what do you want to really learn? So he said that I'm going to practice for next 15 years. So I want to upgrade my skills. I want you to observe me and give me some tips to. So he came for a week and he was so meticulous. So he came first day. I said that you do what you do, and I will just observe and will give you some important tips like which you can use. So after every case, he will ask us like how I want to change or something, and one of our consultants will tell him that these are the things you should improve, and he will note it down. And next day, when he comes to for the surgery, he has that post-it and he will put it on the microscope. Okay, so there are all the points that those has been told to them, And he said that today I want to improve on all these things. So today I'm going to do all these things. So that is how methodical he was, and he was so good.
Wow. That's fantastic. That's the right way of doing things for sure. You've got to get better and better every single case that you do. That is so critically important. And so I think the best residents are the ones who are going to go there and they're going to really,
Sorry.
yeah, I think the
I, I
best.
lost the, I lost the connection in between.
I know what's going on with your internet, buddy. You're killing me. Let's try that. Okay, let me. I'll just start with it. We'll start. I'll cut it off somewhere. I'll figure it out.
Okay. So I was just saying that he was so good and so methodical. I think we also learned so many things from him when he trained with us. So that's amazing. So I think age, I always thought, is a bar for learning, but I think it's mainly the attitude of learning which is really important.
Attitude is everything.
Yeah.
Everything. I've had amazing residents. Like you said, the truth is, and no one will tell you this, there's a bell curve of skill for residents. As you said, a few are exceptionally good, a few are exceptionally bad, most are pretty good, right in the middle. But the differentiator among all residents is how hard, what's your attitude, and how hard do you want to work? When I ask a resident, okay, we're going to do a case today, and then, did you record the case? Oh, I forgot to bring my USB drive. What? Or I said, okay, yesterday you did 3 cases. Did you go home last night and study those cases? What were the points you learned? Oh, I didn't have time to watch it last night.
Yeah.
You could have gone home and watched it at 2x speed. I had to sit there in person while you did it and watch it in real time on an uncomfortable stool in the operating room. I said, you understand when I'm teaching you how to do surgery, it's like a professional race car driver teaching you driver's education, how to drive a car. That's the difference we have here in skills. And the least you could do is show respect by putting in the effort. Like, I love the idea how the guys made a list of here are the things I have to improve on. The best residents would do that. At the end of the case, they would sit and say, okay, professor, tell me, how did I do in this case? And one would say, I still remember this young doctor, he would say, but don't give me any compliments. How did I do? Tell me what I can do better on this case, and I don't want to hear any compliments. Don't. And so I'd say, yeah, okay, well, you know what? You needed to improve this and this and this, and it's not a compliment, but I enjoyed the way you did the other stuff. Okay.
So that's amazing. Attitude. So that's amazing to have that feedback, about our training team also. I have such a great training team because I alone cannot train so many people, as you said.
Right.
So I have got Dr. Umesh Amrade, who is a great trainer, Dr. Nidhi, Dr. Priyanka, Dr. Komal, Dr. Indranil. Many of them are my fellows who have joined me as consultants. And Dr. Umesh, he is amazing teacher because he asks for feedback from the trainee at the end of the day. So he will tell, how was my training? Was I good? You think I should improve on something? So that's the attitude everyone should have. So at the end of the day, we should ask our patients, our colleagues, or our trainees, or our teachers, how was I? Was I good? Can I do something better? I think that's amazing. That's why Dr. Umesh Amrare, who is one of the trainers, is amazing in training. And so is my wife, Dr. Nidhi also. She also trains. So we have amazing team who can do the job.
That's fantastic. I really like that. It's a commitment to lifelong learning for everyone. Professors are going to keep learning. Students, residents, fellows are going to keep learning too. That makes the most sense, of course.
Yeah. Yes.
Now, what advice would you give? You have a young resident who's doing training program, let's say somewhere in Europe, and because of their circumstances, whether it's Germany or Italy or wherever they are, they're not going to be able to do many phacos. They'll finish their whole residency, mostly clinical training. Surgical training will be 20 cataracts, 30 cataracts. What should they do to learn the most during those 20 or 30 cataracts? And then when should they consider coming and doing a short-term program with someone like you?
Yeah. So I think in those 20, 30 cataracts, they should focus on the steps they have done, analyze those steps. Are they good at those? Like, for example, have they mastered the incisions by the end of 20th case? Even that is good enough to start.
Right.
And as I said, I don't mind any surgeon with zero experience. I can teach them. we know how to teach the ophthalmic residents here. And I think most important thing, put those hours, as we discussed, on simulator program, wet lab, wherever you get time. If you don't have access to that, you have such a great YouTube channels,
Right.
and you should go through all the YouTube videos. There are, I think, hours of YouTube videos. If you see them again and again, it will definitely help you.
And I like the John Davis idea of you can
Kitchen lab.
kitchen lab. You can put your mobile phone
Yeah,
so that it has high magnification. That becomes your microscope. You only look at the screen, and you
yeah,
can suture a grape or whatever under the microscope, and the phone's your microscope. That's brilliant.
amazing. So that's how
I
you
think,
you can develop the coordinate.
yeah, for sure. I think you have to learn from every case you do. If you're only going to do 25 cataracts in your residency, well, you better really first record every video, and then you have to be very self-critical. You have to be your own toughest critic. At the end of the day, you go home
Yeah.
and watch the video and say, and take some notes. What can I do better? What needs improvement here? And then the next day, like your 65-year-old friend, put a note on the microscope. Here's what I have to fix today. And the key is that every case should be moving forwards and getting better.
Yes, yes. And there are a few points I would like to share with those who are training, like
Okay.
us. Okay, those are a few things. First thing which we realize is that orthoptic evaluation of a trainee is really important,
Okay.
because many trainees, I have found that they have these accommodation anomalies or convergence problems. So when they actually, start doing surgeries, they are not able to focus well, and
Mm,
sometimes they make mistakes, like they make a side port incision and they are struggling to get in many times. And many times that happens because during that they are not able to relax their accommodation or to achieve that binocularity. So we
right.
found those in few of the trainees, and that was the main struggle they had. And once we corrected those, they became suddenly better surgeons, because now
Oh,
they are seeing everything clearly. So a small thing changed their life. some there was someone who was labeled as a bad surgeon. She came to us. She had opportunity to get training at 2 or 3 centers, but everywhere she had the same struggle, that every time she started she had a lot of complications, so she could not proceed. So she came to me and told me that this is my last chance, so if I can get trained here, otherwise I'm just going to leave the surgery and I will stick to medical practice.
okay.
So I said, let's try. And she had the same problem. Okay, so there was a nice thing which we did. So we did the orthoptic evaluation, and she had accommodation excess. So she had to relax her accommodation. And main problem with that is the feedback. So we shifted her to Ingenuity heads-up visualization system. So
Oh,
as you know, here the accommodation has no role to play.
right.
You have to focus it on these, the TV screen, and you cannot accommodate. So that feedback of accommodating more and more got lost. So after
Mm,
10 cases, now we shifted her back to regular microscope, and she was now doing things very easily, and she could complete 100 cases in a month without
what?
any complication. So this was life changing for her, because it just changed her career. So that is one thing, we must get orthoptic checkup done for all those residents who are starting surgeries with us. Second thing, I think you have also pointed it out. We should have a set protocol for each and every step. For example, if the trainee makes a small capsulorhexis, you have to make sure that you enlarge it to 5 to 5.5 mm.
Right.
As I think you have said, the curse of baby rhexis.
The
So
curse
I
of the
think
baby Rexes.
so. I think that has to be so. If the trainee is operating for you, maybe 4.5 rhexis is okay to do phaco,
Right.
but for trainee it has to be minimum 5 to 5.5 mm.
Yes.
So we make sure that all of us who are training, we make sure that we enlarge it for the trainee if the trainee is in the beginning, and we ask them to do it themselves afterwards. So that is also another thing we must tell your trainees. Also, you have to assess the hand-eye coordination. So do not
Mm,
suddenly ask the trainee to do chop unless you have a perfect case and you feel that the trainee is ready for doing the chop. So just for hastening the learning curve, you should not push the trainee too hard. I think even doing divide conquer properly in all cases is also fine, because that
right.
is all right for some surgeons, I think. So these are few things we learned over a period of time, which I wanted to convey, because that will definitely help the trainers all around the world.
Yeah, it makes a lot of sense. I mean, of having these accommodative issues, I totally understand it now. I was going to say, put a drop of tropicamide in each eye. Now do the case. You know?
Yeah, and another thing which I realized that it's surprising, though it looks very, I would say, common sense, that not all ophthalmologists get their refraction done.
Right.
So some of them have this astigmatism or some errors which they just don't consider. But when they're operating, it affects their stereopsis
Right.
when you have that. So I think it's always better to get it done. I had one trainee who had done who had undergone cataract surgery herself and had a trifocal in one eye and myopia in the other eye. And so she was operating with contact lens in one eye and with the multifocal, and she was having a lot of trouble. So
Sure.
we realized it once we did her evaluation that that was the problem, because her trifocal eye had refractive error which was not corrected, and
Ah,
that's why the stereopsis was not good. So these are the things which are really useful once you start training these short term trainings.
that makes a lot of sense. But the good news is, as you get older, as you approach age 50 and beyond, I promise the accommodation will drop dramatically.
Yeah, yeah, that's true, that's true.
Like if you see my videos, like the whole video is totally in focus. Why? Because I have very little accommodation left. I have scope to move up and down because so no, these are such great points. God, that's a lot of learning. Well, you have a fantastic program there, and again, keep up the great work. I'm going to put a link down below for your YouTube channel, which I think is very useful, and I can put a link to your hospital as well if someone wants to come there and do some extra training. Maybe you
Thank
can
you.
teach me how to do parts plane of vitrectomy. I never learned, so
I'm ready for that. And I'm so grateful to my all my parents and teachers, who had got me
of
till this
course.
point. I think the gratitude and attitude will give you the altitude. That's what I feel. So I think we should always be grateful for those who have taught us and brought us
Oh,
to this platform.
I like. Let me write this down. Gratitude
And attitude,
and attitude give you the altitude.
altitude.
I love that. I'm writing it down. I'll put that on the title slide for the video.
Thank you, thank you. And even my wife, there is another story for those
Tell
who
me.
are, these are really good things. My wife is a pediatrician to begin with. So when we met, she was doing residency in pediatrics and I was doing in ophthalmology. So we met through retinopathy of prematurity, that's how. And then after our marriage, when we moved to my hometown, so she realized that everyone is speaking about ophthalmology here because my parents are ophthalmologists, I am ophthalmologist. So she said that I will do ophthalmology. And she did ophthalmology, and now she is amazing cataract surgeon and great, trainer. So I think that is how, somebody can learn even after doing residency in some other subject. Because
Sure.
we get many trainees, like mainly the, women who have lost few years because of probably pregnancy, then they have kids, they have a lot of these responsibilities at home, and then they want to start it again. Believe me, they do really really great when they start learning surgery again. So for those who have got break in between, don't worry, you can learn cataract surgery anytime and do really really well.
That is great advice. Sourabh,
Yeah.
I want to say thank you so much for doing this podcast. I really enjoyed such great information. This is a must-listen podcast for any young ophthalmologist. You've got to listen to this podcast. So many great pearls.
Thank you so much for the kind invitation. It was amazing 1 hour. Thank you.
Oh, thank you. And remind my listeners and viewers, remember, we got a new podcast every single Sunday. It's on Apple, Amazon, Spotify, Google. Anywhere you find a podcast, you find the CataractCoach podcast. Plus, of course, we now have the Retina Rounds podcast, also every Sunday, everywhere you find podcasts. We have a new CataractCoach video every single day. We got a new Retina Rounds video every single day. So until next week, I'll catch you later.